Hi, I'm Joseph Sivak. I'm one of the cardiology fellows at Duke University. I'm joined here by Dr. Brent Muhlestein, who presented yesterday the results of the Factor 64 trial, looking at using coronary CT angiography in screening patients with diabetes, asymptomatic patients with diabetes. Dr. Muhlestein, would you be able to summarize the results of the trial for us?
Yes, basically the hypothesis was that there's lots of patients who have diabetes who also have underlying coronary artery disease, and many of them, their first symptom is a heart attack or death, and so we'd like to catch them before those happen. So maybe we could do it by screening them using 64-slice CT coronary angiography. So we certainly probably could screen them, but whether or not we can make a difference in their outcome was the big question. Therefore, we randomized 900 patients who were deemed to be high risk for coronary artery disease, who were diabetic, and then half of them received the scan and half of them didn't get the scan, and then we followed them for an average of 4 years. In the patients who got the scan, we didn't just want to know about it, we wanted to recommend more aggressive medical management strategies, and so about 8 to 12% of them actually got revascularization of some sort, and all of them were recommended higher, more aggressive medical management strategies with more extreme targets of LDL and other blood pressure and blood sugar measures. And in the end, after following them for 4 years, we found no significant difference between the outcomes of those who got screened and then the recommendations based on it versus those who were just treated with optimal medical management throughout the Intermountain Healthcare's diabetic medical management system.
So one of the things that I thought was most impressive about the study, and that came up in the discussion afterwards yesterday, was the very low event rate in both groups. The diabetic patients had an event rate in the 2% range over the course of follow-up. So I was hoping you could describe for us kind of the structure of the Intermountain healthcare system and what you think some of the features of it that kind of led to that low event rate.
Yes, that was sort of an interesting aspect of the study because we powered our study expecting 8% per year adverse event rate, which was based on Intermountain Healthcare diabetic patients from the 10 years before we started the study. And so we were having very high events rates just like the rest of the world was. But sort of simultaneous with us initiating the onset of our study, Intermountain Healthcare, through the cardiovascular clinical program in conjunction with the primary care clinical program, developed a new diabetes management program in which they identified all of the patients who were diabetic throughout the Intermountain Healthcare system and set up targets and goals for management, which met the standard goals. They said they met or at least they tried to get LDL less than 100, hemoglobin A1C less than 7, and systolic blood pressure less than 130 were their 3 primary targets. And then they set up a system of feedback so that the physicians were told who their diabetic patients were and that they were being tracked. And they also got feedback as to how they were doing with the targets, what their blood pressure was, and they received lists back of which of their patients were not on target. And just recently I heard that the system has become such that now there's a financial incentive so that they get paid a little more if they get their patients to target.
Oh, wow.
And so under those sorts of situations, right at the same time we were attempting to try to do our study, the event rates dramatically reduced because of aggressive medical management on all of the patients.
Right.
Additionally, after we started the study, the other thing we thought we would do is identify patients who were about to have a heart attack and die from it, but they had severe disease, underlying severe disease, and then we would do revascularization therapy, and by the revascularization therapy we would prevent that heart attack. But as you know, a couple of studies have demonstrated that revascularization is not all that effective at reducing heart attacks and death in patients because a lot of times the heart attacks occur in non-severe plaques which are not necessarily revascularized. Results from the Berry 2D trial, which was in at least mildly symptomatic diabetic patients, demonstrated that aggressive medical management may be just as good. And so our revascularization didn't necessarily change the outcome either. So in the end, the conclusion that I take is aggressive medical management of every diabetic patient is the way to go.
Yeah. And, one other thing that I noticed is, so in the group where there was a finding on CTA, they were put on even more aggressive therapy. So hemoglobin A1C less than 6, LDL goal less than 70. But I guess given the fact that both groups ended up with similar event rates, does that kind of say that maybe that extra aggressive therapy isn't maybe necessary? Maybe that initial goal of LDL less than 100 and A1C less than 7 is probably the right goal?
I think probably the more aggressive goals are still beneficial. Another thing to remember is there was 20% reduction, but it was not statistically significant because
That's
the
fair.
overall event rate was so low.
That's fair.
And as you recall, in that same presentation, there was the Improve It trial, which had an 8% reduction. But of course, they had 18,000 patients to document it.
Right.
But the whole world believes that that 8% real reduction is still useful. And so I think that the additional targets, and we're going to follow these patients long term, but of course now they're all on the same targets. But my guess is we still may be able to see a separation. So I think those aggressive targets, and that's also justified by the fact that 70% or more of all the patients were found to have underlying coronary artery disease by CT angiography. And so it's almost like all diabetics have underlying coronary artery disease if you check them all. So you might as well aggressively treat them all. And also the Improve It trial demonstrates, especially from a lipid standpoint, that going even lower is probably not bad, it's probably good. Now, relationship to blood sugar, as you know from the Accord trial, it demonstrated that you have to watch out for hypoglycemia in those patients. And so even though the aggressive target was 6, once that Accord trial came out, we sort of de-emphasized that guideline.
That's
because fair. So I think that's about how to think about that.
Okay. Well, thank you so much for your time, and please look at the Duke Fellows blog, DukeCardiologyFellows.org, for more information, more interviews. Thank you.
Thank you very much.